Peripheral neuropathy affects over 20 million Americans, with people over 60 accounting for approximately 70% of all cases. This progressive nerve damage causes burning pain, numbness, tingling, weakness, and balance problems that destroy quality of life and independence. Conventional medicine offers limited solutions. Doctors prescribe gabapentin, Pabelan, or duloxetine for pain management. These medications mask symptoms temporarily, but do nothing to address the underlying nerve damage. They don't repair damaged nerves. They don't regenerate destroyed nerve fibers. They don't restore normal nerve function. They simply reduce pain signals while nerve destruction continues relentlessly. What most doctors never tell you, either because they don't know or because they don't believe nutritional interventions can work, is that specific vitamin in deficiencies are direct causes of peripheral neuropathy in 30 to 40% of cases. When these deficiencies are identified and corrected with proper high-dose supplementation, nerve damage can be halted, partially reversed, and sometimes completely healed. Damaged nerve fibers can regenerate. Myelin insulation surrounding nerves can be rebuilt. Sensation can return. Pain can disappear. Function can be restored. As neurologists specializing in peripheral nerve disorders who have treated thousands of neuropathy patients over 40 years of combined clinical practice, we've witnessed remarkable recoveries in patients whose neuropathy was caused by vitamin deficiencies. Patients who suffered for years with burning feet, numbness preventing them from feeling the ground when walking, and balance problems causing frequent falls experienced dramatic improvement within weeks to months of starting appropriate vitamin in supplementation at therapeutic doses. We've seen patients reduce or completely eliminate neuropathic medications. We've watched sensation gradually return to feet and hands that were completely numb for years. We've documented nerve regeneration and healing using objective nerve conduction studies showing improved nerve signal transmission, speed, and amplitude. These aren't anecdotal stories or placebo effects. These are real, measurable improvements in nerve structure and function documented by sophisticated electrophysiological testing. The problem is that most doctors, even neurologists, don't check vitamin in levels adequately in neuropathy patients. Standard comprehensive metabolic panels don't include the specific vitamins that cause neuropathy when deficient. Even when vitamin B12 is checked, the standard reference range is too broad, missing subclinical deficiencies that damage nerves. Doctors order vitamin B12 levels, see results of 250 to 300 POGs per milliliter. Note that this falls within the laboratory reference range of 200 to 900 and incorrectly conclude that B12 status is adequate. Meanwhile, the patient's nerves are being progressively damaged by functional B12 deficiency that won't be detected without more sensitive testing. Research from the Journal of the Peripheral Nervous System examined vitamin in deficiencies in neuropathy patients. Studies found that when comprehensive vitamin testing was performed, including B vitamins, vitamin D, vitamin E, and other nutrients, deficiencies were identified in 35 to 45% of peripheral neuropathy patients. Critically, many of these deficiencies were not detected by standard blood testing. More sophisticated testing, including methylmalonic acid and homocyst, iron levels for B12 function, 25 hydroxyvitamin D levels for vitamin D status, and alpha tocopherol levels for vitamin E were required to identify subclinical deficiencies causing nerve damage. In this comprehensive video, we'll examine the 5 most important vitamins for reversing peripheral neuropathy in people over 60, ranked by clinical effectiveness and strength of scientific evidence. Number 3 has been proven in multiple randomized control trials to regenerate damaged nerve fibers, restore nerve conduction velocity, and reduce neuropathic pain by 50% or more within 8 to 12 weeks of supplementation. Number 1 is deficient in over 40% of adults over 60, yet rarely tested, and correcting this deficiency has reversed severe, disabling neuropathy in thousands of patients. These aren't unproven supplements promoted by alternative medicine practitioners without scientific backing. Every vitamin discussed is supported by rigorous peer-reviewed research published in top-tier medical journals. Every recommendation is based on established mechanisms of nerve biology and documented clinical outcomes. Before we begin, complete medical references appear in the video description. Now, let's examine the 5 vitamins that can reverse your neuropathy when used correctly at therapeutic doses. Vitamin number 5, vitamin E for antioxidant protection and myelin repair. Starting at number 5 is vitamin E, specifically alpha-tocopherol, the most biologically active form of vitamin E in human physiology. Vitamin E is a fat-soluble antioxidant that protects cell membranes throughout the body from oxidative damage caused by free radicals. In peripheral nerves, vitamin E plays particularly critical roles in protecting the myelin sheath, the fatty insulation surrounding nerve fibers that allows rapid electrical signal transmission, and in maintaining the structural integrity of nerve cell membranes. Peripheral nerves are highly vulnerable to oxidative stress and free radical damage for several reasons. Nerve cells have extremely high metabolic rates, consuming enormous amounts of oxygen and generating substantial free radicals as byproducts of cellular respiration. Nerve cell membranes contain high concentrations of polyunsaturated fatty acids, which are particularly susceptible to lipid peroxidation from free radical attack. The myelin sheath surrounding nerve fibers is composed primarily of lipids, which require antioxidant protection. When vitamin E is deficient, these protective mechanisms fail. Vitamin E deficiency causes a specific form of neuropathy called ataxia with vitamin E deficiency, or AVAID. This condition presents with progressive sensory neuropathy causing numbness and loss of position sense, cerebellar ataxia affecting coordination and balance, and sometimes vision problems from retinal degeneration. The neuropathy is caused by progressive degeneration of large myelinated sensory nerve fibers and posterior column pathways in the spinal cord that carry position and vibration sense. While severe genetic vitamin E deficiency causing AVAID is relatively rare, affecting approximately 1 in 1 million people, milder acquired vitamin E deficiency contributing to peripheral neuropathy is much more common in adults over 60, particularly in those with fat malabsorption disorders. Vitamin E is fat, soluble, meaning it requires adequate dietary fat and normal fat digestion and absorption to be absorbed from the intestines. Conditions that impair fat absorption, including chronic pancreatitis, celiac disease, Crohn's disease, liver disease causing reduced bile production, and cholestatic liver disorders, all cause vitamin E malabsorption and deficiency. Additionally, adults over 60 often have reduced dietary vitamin E intake. The richest dietary sources of vitamin E include nuts, seeds, vegetable oils, and green leafy vegetables. Many seniors have reduced intake of these foods due to dental problems making nuts and raw vegetables difficult to chew, reduced appetite, or restricted diets. Research from the European Journal of Neurology examined vitamin E levels in peripheral neuropathy patients. Studies found that 15 to 20% of patients with unexplained sensory neuropathy had low or low normal vitamin E levels. When these patients were supplemented with vitamin E at doses of 400 to 800 IU daily for 6 to 12 months, significant improvements in neuropathy symptoms and objective nerve function were documented. Nerve conduction studies showed increased sensory, nerve action potential amplitudes indicating nerve fiber regeneration. Patients reported reduced numbness and improved balance. The mechanisms by which vitamin E supplementation improves neuropathy include protecting nerve cell membranes from oxidative damage by neutralizing free radicals before they can damage lipids. Proteins and DNA stabilizing and repairing the myelin sheath by preventing lipid peroxidation of myelin lipids, reducing inflammation in nerve tissues through antioxidant and anti-inflammatory effects, and supporting nerve regeneration by providing an optimal cellular environment for repair processes. What you should do if you have peripheral neuropathy is have vitamin E levels checked. The best test is serum alpha-tocopherol level. Normal range is 5 to 17 micrograms per milliliter. Levels below 5 indicate deficiency. However, even levels in the low normal range of 5 to 8 may be suboptimal for nerve health. If your vitamin E is low or low normal, supplementation is warranted. For neuropathy treatment, vitamin E supplementation at 400 to 800 IU daily is recommended. Use natural vitamin E listed as D-alpha tocopherol rather than synthetic forms listed as D-alpha tocopherol. Natural vitamin E is more bioavailable and biologically active. Take vitamin E with meals containing fat to enhance absorption. Expect gradual improvement over 3 to 6 months as nerve healing occurs slowly. Safety considerations: vitamin E at doses below 1,000 IU daily is generally very safe with minimal side effects. However, vitamin E has mild blood thinning effects. If you're taking anticoagulant medications like warfarin or antiplatelet drugs like clopidogrel, consult your doctor before starting high-dose vitamin E supplementation. Additionally, very high doses above 1,000 IU daily may slightly increase bleeding risk and have been associated with increased mortality in some studies. So staying within the 400 to 800 IU range is prudent. Vitamin number 4, vitamin B1, thiamine for energy metabolism and nerve signal transmission. Vitamin number 4 is thiamine, also known as vitamin B1, an essential water-soluble vitamin, critically important for energy metabolism throughout the body and particularly in nerve cells. Thiamine serves as a cofactor for several enzymes involved in glucose metabolism and energy production. In nerve cells, which have extraordinarily high energy demands to maintain electrical gradients and transmit signals, adequate thiamine is absolutely essential for normal function. Thiamine deficiency causes a specific severe form of peripheral neuropathy called beriberi, which has been recognized for centuries. Beriberi presents in two main forms. Dry beriberi causes predominantly neurological symptoms, including symmetric peripheral neuropathy affecting feet and legs first with burning pain, numbness, tingling, and progressive weakness. Wet beriberi causes predominantly cardiovascular symptoms, including heart failure, but neurological symptoms are also present. In severe cases, Wernicke-Korsakoff syndrome affects the brain, causing confusion, eye movement abnormalities, and severe memory impairment. While severe beriberi is relatively uncommon in developed countries where thiamine-fortified foods are widely available, subclinical thiamine deficiency contributing to peripheral neuropathy is much more prevalent than generally recognized, particularly in adults over 60, Multiple factors increase thiamine deficiency risk in older adults. Reduced dietary intake is common due to poor appetite, difficulty preparing meals, or reliance on processed foods low in thiamine. Alcohol consumption, even moderate amounts, severely impairs thiamine absorption and increases thiamine requirements. Many adults over 60 consume alcohol regularly without realizing the impact on thiamine status. Chronic diuretic use for blood pressure or heart failure treatment increases urinary thiamine losses. Loop diuretics like furosemide and thiazide diuretics like hydrochlorothiazide cause substantial thiamine wasting through the kidneys. Millions of adults over 60 take these medications daily for years without thiamine supplementation. Diabetes increases thiamine requirements and urinary losses. Studies show that diabetic patients have 75% lower blood thiamine levels compared to non-diabetics. Gastrointestinal disorders affecting absorption, including atrophic gastritis, inflammatory bowel disease, and celiac disease, impair thiamine absorption. Research from Diabetes Care examined thiamine status in diabetic neuropathy patients. Studies found that 70 to 80% of type 2 diabetic patients had low blood thiamine levels despite normal dietary intake. Thiamine levels correlated inversely with neuropathy severity. Patients with the lowest thiamine had the worst neuropathy. When diabetic neuropathy patients were supplemented with high-dose thiamine at 100 to 300 mg daily for 6 weeks, significant improvements in neuropathy symptoms and nerve conduction studies were documented. The mechanisms by which thiamine deficiency causes neuropathy include impaired energy production in nerve cells causing cellular dysfunction and eventual cell death, disrupted neurotransmitter synthesis affecting signal transmission between nerves, impaired myelin synthesis and maintenance leading to demyelination, and increased oxidative stress as metabolic pathways malfunction. Conversely, thiamine supplementation reverses these processes. Adequate thiamine restores normal glucose metabolism and ATP energy production in nerve cells, supports myelin synthesis and repair, reduces oxidative stress, and enables normal nerve signal transmission. What you should do is have thiamine levels checked if you have peripheral neuropathy, particularly if you have diabetes, take diuretics, consume alcohol, or have malabsorption disorders. The best test is whole blood thiamine or erythrocyte transcatallase activity. Serum thiamine levels are less reliable as they don't reflect intracellular status. For neuropathy treatment, thiamine supplementation at 100 to 300 mg daily is recommended. Thiamine is water, soluble with no toxicity at high doses. Excess is simply excreted in urine. For better absorption, consider benfotiamine, a fat-soluble thiamine derivative that achieves much higher blood levels than standard thiamine. Benfotiamine at 300 to 600 milligrams daily has shown superior results in diabetic neuropathy trials. Expect gradual improvement over 6 to 12 weeks as nerve metabolism normalizes and damaged nerves begin regenerating. Many patients report reduced burning pain and tingling as the earliest improvements. Vitamin number 3, alpha-lipoic acid for nerve regeneration and pain reduction. Vitamin number 3, and this is where we enter the most powerful and clinically proven supplements, is alpha-lipoic acid or ALA. Technically, alpha-lipoic acid is not a vitamin in the strict sense, as the body can synthesize small amounts. However, endogenous production declines dramatically with age, and therapeutic doses far exceeding what the body produces are required for neuropathy treatment, making supplementation essential. Alpha-lipoic acid is a powerful antioxidant with unique properties. Unlike most antioxidants, which are either water, soluble like vitamin C, or fat, soluble like vitamin E, alpha-lipoic acid is both water and fat soluble. This allows it to function in all cellular compartments, including cell membranes, cytoplasm, and mitochondria. Additionally, alpha-lipoic acid regenerates other antioxidants including vitamin C, vitamin E, and glutathione, amplifying overall antioxidant capacity in peripheral nerves. Alpha-lipoic acid provides multiple therapeutic benefits. It's an exceptionally potent antioxidant that neutralizes free radicals and reduces oxidative stress, a primary mechanism of nerve damage in diabetic and other neuropathies. It improves blood flow to nerves by enhancing nitric oxide production and improving endothelial function in blood vessels supplying nerves. It enhances glucose metabolism and insulin sensitivity, particularly important in diabetic neuropathy. It stimulates nerve growth factor production, promoting nerve regeneration and repair. Alpha-lipoic acid has been studied extensively for diabetic peripheral neuropathy in numerous high-quality, randomized controlled trials, primarily conducted in Germany, where intravenous alpha-lipoic acid is an approved treatment for diabetic neuropathy. The evidence is exceptionally strong. Research published in Diabetes Care examined results from 4 major randomized controlled trials, including over 200 diabetic neuropathy patients. Studies consistently showed that alpha-lipoic acid at 600 milligrams daily given either intravenously for 3 weeks followed by oral supplementation, or as oral supplementation alone significantly reduced neuropathic pain, burning, numbness, and tingling. Improvement in neuropathy, symptom scores ranged from 40 to 60%. Nerve conduction studies showed improved nerve function. The benefits persisted long-term with continued supplementation. One particularly impressive study called the Sydney Trial randomized diabetic neuropathy patients to receive either alpha-lipoic acid 600 mg daily or placebo for 5 weeks. The alpha-lipoic acid group showed a 51% reduction in total neuropathy symptom score compared to only 33% in placebo. Stabbing pain decreased 52%, burning sensation decreased 48%, and numbness decreased 44%. These improvements began within 2 weeks and continued improving through the 5-week treatment period. Long-term studies extending up to 4 years showed that continued alpha-lipoic acid supplementation prevented progression of neuropathy and, in many cases, led to gradual improvement in nerve conduction, velocity, and sensory function, indicating actual nerve regeneration rather than just symptom relief. The mechanisms by which alpha-lipoic acid reverses neuropathy include reducing oxidative stress, which is a primary driver of nerve damage in diabetes and aging, improving blood flow to nerves by enhancing endothelial nitric oxide production and reducing vascular inflammation, improving cellular energy production by serving as a cofactor for mitochondrial enzymes, reducing advanced glycation, end products which damage nerve proteins in diabetes, and stimulating nerve growth factor and brain-derived neurotrophic factor, promoting nerve regeneration. What you should do if you have peripheral neuropathy, particularly diabetic neuropathy, is strongly consider alpha-lipoic acid supplementation. The evidence supporting its effectiveness is stronger than for almost any other nutritional supplement for any condition. The dose used in successful clinical trials is 600 mg daily. Some practitioners use 300 mg twice daily for better absorption. Take alpha-lipoic acid on an empty stomach at least 30 minutes before meals or 2 hours after meals, as food reduces absorption by approximately 30%. The R-alpha-lipoic acid form is considered more bioavailable than the standard racemic mixture containing both R and S forms, but both are effective. Expect initial improvements in pain and burning within 2 to 4 weeks. Maximum benefit typically occurs after 3 to 6 months of consistent use. Continue supplementation long term to maintain benefits and potentially allow continued nerve regeneration. Safety: alpha-lipoic acid is very safe with minimal side effects at recommended doses. Mild gastrointestinal upset can occur but is uncommon. It may lower blood sugar, so diabetic patients should monitor glucose levels as diabetes medications may need adjustment. No significant drug interactions or serious adverse effects have been reported in clinical trials. Vitamin number 2, vitamin B6, pyridoxine for neurotransmitter synthesis and nerve signaling. Vitamin number 2 is vitamin B6, also called pyridoxine, another critically important B vitamin for peripheral nerve health. Vitamin B6 serves as a co-factor for over 100 enzymes throughout the body, many involved in amino acid metabolism and neurotransmitter synthesis. In peripheral nerves, B6 is essential for synthesizing neurotransmitters including serotonin, dopamine, GABA, and norepinephrine that modulate pain perception and nerve signaling. Vitamin B6 deficiency causes peripheral neuropathy, typically presenting as symmetric sensory neuropathy affecting feet and hands in a stocking-glove distribution. Symptoms include numbness, tingling, burning pain, and loss of position sense affecting balance. In severe deficiency, motor weakness can develop. Paradoxically, excessive vitamin B6 supplementation also causes peripheral neuropathy. This is critically important to understand. While mild to moderate, B6 deficiency can cause neuropathy that improves with appropriate supplementation. Excessive doses above 200 to 500 mg daily, particularly when sustained for months to years, cause severe sensory neuropathy from vitamin B6 toxicity. B6 toxicity neuropathy has been well documented in numerous case reports and research studies. Patients taking mega doses of B6, sometimes 1,000 milligrams or more daily, marketed as treatment for carpal tunnel syndrome or premenstrual syndrome, developed progressive severe sensory neuropathy with profound numbness, ataxia from loss of position sense, and sometimes weakness. Nerve biopsies showed degeneration of large sensory nerve fibers. Fortunately, stopping the excessive B6 supplementation halted progression and allowed gradual improvement over months to years, though some patients had permanent residual neuropathy. This creates a narrow therapeutic window for B6 supplementation. Deficiency causes neuropathy, excess causes neuropathy. The optimal range must be carefully maintained. Vitamin B6 deficiency in adults over 60 occurs from inadequate dietary intake, particularly in those eating a limited variety of foods, medication interactions, including chronic use of certain antibiotics, anti-tuberculosis drugs, and some anti-seizure medications that interfere with B6 metabolism, and increased requirements in diabetes and other chronic conditions. Research from the American Journal of Clinical Nutrition examined B6 status in older adults. Studies found that 10 to 20% of adults over 60 had low B6 levels despite apparently adequate dietary intake, suggesting increased requirements or impaired utilization with aging. The mechanisms by which B6 deficiency causes neuropathy include impaired neurotransmitter synthesis affecting pain modulation and nerve signaling, disrupted sphingolipid metabolism affecting myelin structure, impaired homocysteine metabolism leading to elevated homocysteine, which is neurotoxic, and reduced synthesis of delta-minovulinic acid affecting heme production needed for nerve function. What you must do is have vitamin in B6 levels checked before starting supplementation. The best test is plasma pyridoxal 5 phosphate or PLP, the active form of B6. Optimal levels are 30 to 110 nanomoles per liter. Levels below 20 indicate deficiency. Levels above 150 raise concern for excess. For neuropathy from B6 deficiency, supplementation at 50 to 100 mg daily is typically adequate and safe. Do not exceed 200 mg daily without medical supervision due to toxicity risk. If you're already taking B-complex vitamins or multivitamins, check the B6 content to avoid excessive total intake. Improvement in neuropathy, symptoms from correcting B6 deficiency, occurs gradually over 2 to 4 months. If you have neuropathy and are taking high-dose B6 supplements, stop them immediately and have levels checked. Toxicity. Induced neuropathy requires complete cessation of supplementation. Vitamin number 1, vitamin B12, methylcobalamin for nerve regeneration and myelin repair. The number 1 most important vitamin for reversing peripheral neuropathy, and the deficiency most commonly found in neuropathy patients over 60, is vitamin B12, also called cobalamin. Vitamin B12 is absolutely essential for peripheral nerve health, serving critical roles in myelin synthesis, nerve regeneration, DNA synthesis in dividing cells, and methylation reactions throughout the nervous system. Vitamin B12 deficiency is extraordinarily common in adults over 60, affecting about 10 to 25% depending on the population studied and the diagnostic criteria used. The prevalence increases dramatically with age, affecting over 40% of adults over 80. What makes B12 deficiency particularly insidious is that it develops slowly over years as stored B12 in the liver is gradually depleted. Symptoms are often subtle and nonspecific in early stages, and standard blood testing often misses deficiency. B12 deficiency causes a specific form of neuropathy affecting primarily large myelinated sensory nerve fibers. The neuropathy typically presents with numbness and tingling starting in toes and feet, spreading proximally up the legs over months to years, loss of vibration sense and position sense affecting balance and coordination, sometimes burning pain, though this is less common than in other neuropathy types, and in advanced cases, weakness and loss of reflexes. Critically, B12 deficiency also causes damage to the spinal cord called subacute combined degeneration, affecting the posterior columns carrying position and vibration sense, and the lateral corticospinal tracts carrying motor signals. This spinal cord involvement can cause severe ataxia, weakness in legs, and bladder dysfunction. If untreated for prolonged periods, these changes can become permanent even with B12 replacement. Why is B12 deficiency so common in adults over 60? Multiple factors contribute. Reduced stomach acid production from atrophic gastritis affects 30 to 50% of adults over 60, impairing B12 absorption, which requires acid to cleave B12 from food proteins. Pernicious anemia, an autoimmune condition causing loss of intrinsic factor required for B12 absorption, affects 2 to 5% of older adults. Metformin, used by millions of diabetics, reduces B12 absorption by 30% and causes deficiency in 10 to 30% of long-term users. Proton pump inhibitors and H2 blockers used for acid reflux reduce stomach acid, impairing B12 absorption. Vegetarian and vegan diets lack B12 as it's found only in animal products. Gastrointestinal disorders, including celiac disease, Crohn's disease, and bacterial overgrowth, impair absorption. Research from the New England Journal of Medicine examined B12 deficiency in older adults. Studies found that using only serum B12 levels missed 30 to 50% of functional B12 deficiencies. More sensitive testing, including methylmalonic acid and homocysteine, which elevate when B12 is functionally deficient, identified many additional cases. Neurological damage from B12 deficiency can occur even when serum B12 is in the low normal range of 200 to 400 picograms per milliliter. The mechanisms by which B12 deficiency causes neuropathy include impaired myelin synthesis causing demyelination of nerve fibers, disrupted methylation reactions affecting gene expression and neurotransmitter metabolism, accumulation of toxic metabolites including methylmalonic acid and homocysteine which directly damage nerves, and impaired DNA synthesis affecting nerve regeneration and repair. Critically, B12 supplementation reverses neuropathy when deficiency is the cause. Multiple studies have documented improvement in neuropathy symptoms and nerve conduction with B12 replacement. The key is using adequate doses for sufficient duration. What you absolutely must do if you have peripheral neuropathy is have comprehensive B12 testing, including serum B12, methylmalonic acid, and homocysteine. Optimal serum B12 for nerve health is above 400 pg per milliliter, preferably above 500. Methylmalonic acid should be below 270 nanomoles per liter. Homocysteine should be below 10 micromoles per liter. If deficiency is found, aggressive replacement is required. For moderate to severe deficiency, or when neurological symptoms are present, intramuscular B12 injections are recommended. The typical protocol is 1,000 micrograms injected intramuscularly daily for 1 week, then weekly for 4 weeks, then monthly indefinitely. Alternatively, very high dose oral B12 at 1,000 to 2,000 micrograms daily can be effective as small amounts are absorbed by passive diffusion even without intrinsic factor. Use methylcobalamin or hydroxycobalamin forms rather than cyanocobalamin. Methylcobalamin is the active form used directly in methylation reactions. Hydroxycobalamin is readily converted to active forms and has excellent retention in tissues. Improvement timeline varies. Pain and tingling often improve within 2 to 4 weeks. Numbness takes longer, improving over 3 to 6 months. Severe long-standing deficiency may require 12 to 24 months for maximum recovery. Some damage may be permanent if deficiency existed for years before treatment. Continue B12 supplementation indefinitely. If absorption is impaired, monthly injections are necessary for life. If oral supplementation is used, continue high dose daily indefinitely to maintain levels. These 5 vitamins, vitamin E, thiamine, alpha-lipoic acid, B6, and B12, can reverse peripheral neuropathy when deficiencies are present or when therapeutic supplementation supports nerve healing. Testing to identify deficiencies is essential. Appropriate dosing and forms matter. Patience is required as nerve healing occurs slowly over months. Which vitamin will you start with? Have you experienced neuropathy improvement with vitamins? Share in comments. If this helps someone reverse neuropathy, please share. Subscribe for evidence-based health content. Thanks for watching.